Welcome to Studious. In this video, we present a complete surface anatomy blueprint of the male body, a visual study guide that maps every major external landmark used during physical examination. Surface anatomy is the first tool a clinician reaches for before any imaging, any blood test, or any procedure. It gives trained hands and eyes a map of what lies beneath the skin. In this atlas, structures are color-coded into 3 categories. Blue for bony landmarks, the underlying skeletal structures that push upward against the skin. Red for soft tissue, the muscles and connective tissue shaping the body's curves. And gold or orange for depressions and organs, the empty spaces, fossae, and external organ boundaries that complete the picture. Together, these 3 layers create a 3-dimensional clinical blueprint of the male body that we'll explore region by region, from the neck and chest, through the abdomen and pelvis, and down to the foot. Let's begin.
Before examining individual structures, let's understand why surface anatomy is so foundational to clinical medicine. Surface anatomy provides the underlying map required to execute the 5 core examination techniques that every clinician uses. Inspection, observing the body visually for asymmetry, swelling, or color changes. Palpation, using the hands to feel for tenderness, masses, or pulses. Percussion, tapping the body to assess underlying density. Auscultation, listening with a stethoscope over key surface sites. And function testing, assessing movement, strength, and range of motion. Without a reliable map of what lies beneath the skin, none of these techniques can be performed accurately. The depth diagram on this slide reveals why. A bony prominence creates a skeletal ridge at the skin surface. A muscle belly creates a tissue contour and bulge. And a space, or fossa, between structures creates a skin depression or anatomical void. Each surface finding tells a specific story about the underlying anatomy, and that story is what drives clinical diagnosis.
Let's begin our journey at the anterior neck and shoulder, a region packed with clinically important landmarks. The first structure is the sternocleidomastoid muscle, or SCM, a superficial 2-headed muscle running diagonally from behind the ear down to the sternum and clavicle. It becomes dramatically visible as a raised cord during lateral rotation of the head, and is used to divide the neck into anterior and posterior triangles for clinical navigation. Centrally in the neck sits the larynx, the voice box, which in males develops a highly prominent laryngeal cartilage known as the Adam's apple, or laryngeal prominence. This is caused by the larger angle of the thyroid cartilage in males, a direct result of androgen exposure during puberty. Lateral to the SCM and above the clavicle lies the supraclavicular fossa, a triangular depression that deepens during inspiration and is a key site for lymph node palpation. At the top of the shoulder sits the acromioclavicular joint, the AC joint, a synovial joint forming the bony protrusion at the very peak of the shoulder, commonly injured in contact sports.
Moving down to the chest, 2 major surface features define the anterior thorax. The first is the pectoralis major, the large fan-shaped muscle forming the primary soft tissue contour of the male chest. It originates from the clavicle, sternum, and upper ribs, and converges to insert into the humerus. It is the dominant shoulder joint muscle for adduction and internal rotation, and its well-developed bulk in males creates the characteristic squared, muscular chest profile. Clinically, pectoralis major tears, common in weightlifters, present with a visible deformity of the anterior chest wall. The second landmark is the costal margin, a palpable upside-down V-shaped bony arch formed by the medial margins of ribs 7 through 10, which are connected to each other by cartilage, rather than directly to the sternum. This arch marks the inferior boundary of the thoracic cage and the superior boundary of the abdomen. Clinically, the costal margin is used to locate the liver edge during abdominal palpation, and enlargement of the liver or spleen is measured by how far they extend below it.
The anterior abdomen of a lean, well-muscled male displays a precise anatomical grid created by the architecture of the rectus abdominis muscle and its surrounding fascia. 3 surface lines define this grid. The linea alba, Latin for white line, is a longitudinal midline depression running from the xiphoid process to the pubic symphysis. It is formed by the interlacing of the aponeuroses of the 3 lateral abdominal muscles, creating a fibrous seam down the center of the abdomen. It appears as a visible vertical groove in lean individuals. On either side of the linea alba, the linea semilunaris marks the lateral fusion line of the rectus sheath, the curved vertical line where the lateral abdominal muscle aponeuroses wrap around the rectus abdominis. This line curves gently outward and defines the outer border of the six-pack. Cutting across the muscle horizontally are 3 to 4 tendinous intersections, fibrous bands of connective tissue that segment the rectus abdominis into individual rectangular units, creating the distinct segmented appearance of the abdominal muscles in athletic individuals.
The external male genitalia occupy the inferior anterior region of the trunk and consist of 3 main external structures, each with distinct anatomical and clinical significance. The penis serves dual functions as both the reproductive organ and the distal segment of the urinary tract. It contains 3 cylindrical erectile bodies, 2 corpora cavernosa and 1 corpus spongiosum, which fill with blood during erection. The distal end expands into the glans penis, which is partially or fully covered by the prepuce, also known as the foreskin. The prepuce is a double layer of skin and connective tissue extending from the neck of the glans, and circumcision, its surgical removal, is among the most commonly performed procedures worldwide. The scrotum is an external skin pouch suspended below the penis, consisting of skin and an underlying layer of superficial fascia called the dartos muscle. It houses the 2 testes, the epididymis coiled around each testis, and the spermatic cords containing the vas deferens and testicular vessels. Scrotal examination is essential for detecting testicular cancer, the most common solid tumor in males aged 15 to 35.
The anterior and lateral thigh is dominated by the quadriceps femoris, a 4-headed muscle group that forms the primary visible contour of the entire anterior thigh. The 4 heads are the rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius. They converge into the quadriceps tendon, which attaches to the patella and continues as the patellar tendon below it. The quadriceps is the primary extensor of the knee joint. Every act of standing up, walking, climbing stairs, and jumping depends on it. In athletes, wasting of the vastus medialis, the teardrop-shaped muscle on the inner aspect of the knee, is an early sign of knee joint pathology. The quadriceps tendon attaches to the patella, and the patellar tendon then anchors the patella to the tibial tuberosity, a palpable bony protrusion on the anterior surface of the upper tibia, just below the knee. The tibial tuberosity serves as the final anchor point for the entire quadriceps mechanism. In adolescence, repetitive traction stress at this point causes Osgood-Schlatter disease, a painful condition presenting as a tender, enlarged bump just below the kneecap.
The dorsum of the foot, the upper external surface, is one of the most clinically important regions of the lower limb because it provides direct access to the dorsalis pedis artery pulse. This artery is the continuation of the anterior tibial artery as it crosses the ankle and runs along the top of the foot, typically between the first and second metatarsal bones, just lateral to the tendon of extensor hallucis longus. Palpating the dorsalis pedis pulse is a standard part of the peripheral vascular examination and is used to assess distal blood flow to the foot. Its absence or diminishment can indicate peripheral arterial disease, a condition where atherosclerotic plaque narrows the arteries supplying the lower limb, or acute arterial occlusion following trauma or embolism. In diabetic patients, monitoring of peripheral pulses, including the dorsalis pedis, is performed routinely, as diabetic vascular disease commonly affects distal foot circulation, leading to ulceration and potential amputation. The dorsalis pedis is also used to assess circulation following orthopedic procedures on the lower limb.
Turning to the back of the body, the posterior neck and upper thorax reveal two critical surface landmarks. The first is the vertebra prominence, the highly visible and palpable bony protrusion at the base of the neck, formed by the exceptionally long spinous process of the seventh cervical vertebra, C7. When you bow your head forward and run your finger down the back of your neck, the first large bony bump you feel at the neck-thorax junction is C7. This is the universal starting point for counting vertebral levels on the back, essential for procedures including lumbar puncture, epidural anesthesia, and thoracentesis. The second dominant structure is the trapezius, a large, flat, diamond-shaped muscle covering the posterior neck and upper back. It has three functional portions. The upper fibers elevate the scapula and shoulder shrug. The middle fibers retract the scapula, and the lower fibers depress the scapula. The trapezius is innervated by cranial nerve 11, the accessory nerve, and its weakness following neck surgery results in a characteristic drooping shoulder and difficulty raising the arm above horizontal.
The posterior shoulder and upper limb contain three bony landmarks that are essential for clinical orientation. The first is the spine of the scapula, a prominent bony ridge running horizontally across the posterior surface of the shoulder blade. It divides the scapula into the supraspinous fossa above and the infraspinous fossa below, each housing the supraspinatus and infraspinatus muscles respectively, two of the four rotator cuff muscles. The spine of the scapula can be traced with a fingertip from the medial border of the scapula all the way to the acromion at the shoulder tip. The second landmark is the vertebral border of the scapula, the medial edge of the shoulder blade, running parallel to the thoracic spine and visible in lean individuals. This border is the attachment site of the serratus anterior muscle, and its abnormal protrusion, called winging, indicates serratus anterior weakness from a long thoracic nerve injury. The third landmark is the olecranon, the prominent bony point of the elbow, forming the proximal posterior terminus of the ulna. It is the attachment site of the triceps brachii tendon and is a key landmark during elbow examination and nerve block procedures.
The posterior pelvis presents three surface landmarks that clinicians use constantly. The iliac crest, the curved superior margin of the ilium, is the large palpable ridge forming the top of the hip bone. Running from the anterior superior iliac spine anteriorly to the posterior superior iliac spine posteriorly, the iliac crest is easily felt by placing both hands on the waist. It is the landmark used to identify the level of the fourth lumbar vertebra, the standard needle insertion level for lumbar puncture, and it is also a common bone marrow biopsy site in hematological investigations. Centrally on the posterior pelvis, the sacral triangle is a shallow, skin-colored depression overlying the sacrum, formed by the skin being tethered to the underlying bone, creating a visible dimpling. Within the upper corners of this triangle sit the dimples of Venus, two small circular skin depressions corresponding to the posterior superior iliac spines beneath. These dimples are caused by the attachment of skin to the PSIS through superficial fascia. In clinical practice, they serve as reliable surface markers for the sacroiliac joints, which are assessed in patients with lower back pain and ankylosing spondylitis.
The posterior lower limb is defined by three layered structures, forming an integrated propulsion and stability system. In the posterior thigh, the semimembranosus forms the medial component of the hamstring muscle group, running from the ischial tuberosity down to the medial tibia. Together with the semitendinosus and biceps femoris, it forms the hamstring group, responsible for knee flexion and hip extension. Hamstring strains are among the most common athletic injuries, typically occurring at the muscle-tendon junction during rapid acceleration. Below the knee, the posterior leg is dominated by the triceps surae, the prominent calf muscle group, comprising the gastrocnemius superficially and the soleus beneath it. The gastrocnemius has two visible heads that create the characteristic diamond-shaped calf bulge. Both muscles converge into the Achilles tendon,
the thickest and strongest tendon in the body, which runs as a rigid, visible ridge down the back of the lower leg to insert into the calcaneus. The Achilles tendon is clinically assessed using Thompson's test, squeezing the calf, which should produce plantar flexion of the foot. Absence of movement indicates tendon rupture.
We close with the complete diagnostic matrix, a full cross-reference of every landmark covered in this atlas, organized by body surface and landmark type. On the anterior surface, bony landmarks include the AC joint at the shoulder peak, the costal margin framing the lower chest, and the tibial tuberosity below the knee. Soft tissue landmarks include the sternocleidomastoid, pectoralis major, rectus abdominis, and quadriceps femoris. Depressions include the supraclavicular fossa, linea alba, and linea semilunaris. External organs include the larynx, penis, and scrotum. On the posterior surface, bony landmarks include the vertebral prominence at C7, the spine of the scapula, the medial scapular border, the olecranon, and the iliac crest. Soft tissue landmarks include the trapezius, semimembranosus, triceps surae calf, and Achilles tendon. Posterior depressions include the sacral triangle and dimples of Venus. The posterior surface has no major external organ landmarks. This matrix is your complete revision tool, a one-page summary of the entire male surface anatomy blueprint. Thank you for watching Med Studios.